Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera. Welcome to the Advanced Life Support course this year. I will be presenting the bread and butter, the most important topic in this course, which is arrhythmia treatment algorithms. At the end of this presentation, you should know how to manage cardiac arrest. You should know how to manage tachyarrhythmias. You should know how to manage bradyarrhythmias. First, let's talk about how to manage cardiac arrest patient. In your mind, you should divide the cardiac arrest into two. One is shockable rhythm. Number two is non-shockable rhythm. Shockable rhythm consists of VF and pulseless VT, whereas non-shockable rhythm consists of PEA and asystole. Every 5 years, there will be an update on ALS. But for the last few 5 years, I did not see much changes. However, you should aware that we do have some small changes in terms of drugs and doses. When you have a cardiac arrest scenario, always initiate with your basic life support. What I mean by your basic life support is your assessment of danger, check for response, shout for help, head tilt chin lift, open the airway, check for breathing. If there's no breathing, straight away chest compression. Next, your assistant should connect to the cardiac monitor and you need to analyze the rhythm. Please stop the chest compression when you are analyzing the rhythm. If the rhythm is asystole, immediate continue your chest compression and do everything. When I say do everything in cardiac arrest means your IV assess, you give your adrenaline 1 milligram every 3 to 5 minutes and you intubate early. The dose of adrenaline given is 1 milligram. By protocol, it stated there you may order every 3 to 5 minutes, but just to make things standard, you ask your assistant to give the 1 milligram adrenaline every 3 minutes. Then after 2 minutes, you assess the rhythm, check for the pulse. If there's still pulseless and the rhythm still asystole, then you continue this cycle. What do you need to do if you find out when you analyze the rhythm there is pulseless VT or VF, which are shockable rhythm? Just now, after you assess that patient is unresponsive, no breathing, and you initiate chest compression, and after you analyze the rhythm, you might find that the patient might have VF or pulseless VT. You continue chest compression at the same time you are preparing for shock. Please do not wait for 2 minutes chest compression. You may start giving shock as soon as possible. After you have given the first shock, concentrate on high quality CPR. During the first 2 minutes of chest compression, you may insert IV access and you may take bloods. During this time, again, concentrate on high quality CPR. Just beg the patient. After 2 minutes up, you analyze the rhythm, you feel for the pulse. If the rhythm shows pulseless VT or VF, you need to give the second shock. Only after the second shock, you do everything in cardiac arrest. When I say everything, it means you give your adrenaline 1 milligram every 3 minutes and you intubate the patient after the second shock. After the second shock, you may need to prepare amiodarone 300 milligram. Please just prepare. You don't have to administer at this moment. After the second 2 minutes up, you stop the chest compression, analyze the rhythm, feel for the pulse. If the pulse still pulseless VT or VF, you need to give the third shock immediately. After delivered the third shock, you may give your bolus amiodarone 300 milligram. So how fast your amiodarone is between 1 to 2 minutes. To make things easy, you need to complete your amiodarone just before the next pulse and rhythm check. At this moment, look for the reversible causes. During resuscitation, you must mention about high quality CPR. You should be able to mention about the push hard and push fast, minimize interruption, avoid excessive ventilations. You need to change the compressor every 2 minutes. And initially, you initiate 30 to 2 ratio of compression ventilation and capnography if available. For the advanced airway, you should be able to intubate the patient. However, if you fail, you might need to insert LMA. So, for the drugs, your adrenaline will be administered 1 milligram every 3 minutes. Your first dose bolus of amiodarone 300 milligram bolus after the third shock and subsequently 150 milligram bolus of amiodarone after the fourth shock. In other circumstances, lidocaine might replace amiodarone. The first dose of lidocaine is 1 to 1.5 mg per kilo after the third shock, and subsequent dose is 0.5 to 0.75 mg per kilo after the fourth shock. For this course, you need to memorize all the 5H and the 5Ts for reversible causes. Actually, it's not easy to remember 5H and 5Ts, especially when you are stressed out during cardiac arrest resuscitation. So I suggest approach from the head downwards. Start from the forehead, you check for the temperature, whether there is evidence of hypothermia. Next, downwards, you check the ETT tube. You check whether there is evidence of hypoxia. Ask yourself how's the bagging, if there is chest rise or not. Next, you go downwards to the neck. You check the trachea, whether it's central or not, in view of suspicion of tension pneumothorax. Further down is the chest. In our chest, there is heart and lung. For the heart, ask yourself whether is there any evidence of cardiac tamponade, which you need to confirm by ultrasound, or whether there is evidence of MI. For the lung, ask yourself whether patient have tension pneumothorax and whether patient have PE, pulmonary embolus. Again, you need an ultrasound to confirm it. After that, you go to the patient's forearm. In the patient's forearm, there will be granula with fluids. Ask yourself whether patient is having hypovolemia. And this is the site where you take blood just now. So you ask for any evidence of acidosis, any evidence of hypo or hyperkalemia. Finally, you ask for the history of toxin indigestion. You should ask from the witness or from the family members. So there goes how we approach the reversible causes. So in a non-shockable rhythm, you may administer adrenaline as soon as possible. However, for shockable rhythm, you need to give shock first, only then you give your adrenaline. Why is that? Because chances of success reduce up to 10% each minute if you delay your shock or your defibrillation. So this is just for your knowledge. Double sequential defibrillation is not recommended. And this is your post-cardiac arrest care. To make things easier, you start from the head downwards. You ensure that you close the patient's eyes with iPad. You insert the rice tube. You anchor the ETT tube. You connect it to the ventilator. Do a chest X-ray. Do a ECG. Check the blood pressure whether patient needs inotropic support or patient needs fluids. Don't forget your peptic ulcer prophylaxis and put patient under comfortable room temperature. Your aim of resuscitation is here. So we try to achieve this during post-resuscitation. Just for your nice to know things, high dose adrenaline is not recommended. There is role of amiodarone or lidocaine during resuscitation. This slide highlight that whenever you do an IV access, it should not interfere with the chest compression. In fact, if you did not able to get IV access, you may perform interosseous. Next, I just want to share with you the field protocol, focus echocardiographic evaluation in life support. Basically, this is a step where a sonographer or an a person with ultrasound knowledge perform this field protocol without interrupting the chest compression and the CPR process. Studies show that there may be a clinically relevant benefit of controlling the body temperature at 36 degrees Celsius uh, instead of allowing fever to develop in patients who have been resuscitated after cardiac arrest, especially those with pulseless VT or VF. Next, we are going to talk about bradyarrhythmia and tachyarrhythmia management. Bradycardia is when the heart rate is less than 60. However, if the heart rate is less than 50, always think about bradyarrhythmia. So initially, you need to assess whether the bradycardia is stable or unstable. So basically, it depends on the whether there's any evidence of altered mental status, any evidence of chest pain, any evidence of sudden acute shortness of breath, any evidence of hypotension or cold peripheries. The management is the same. If any evidence of hemodynamic instability due to hypotension, we need to give adrenaline 1 milligram up to 3 milligram. So this is a new update, okay? Before this, we give 0.5 milligram up to 3 milligram, but now we start 1 milligram up to 3 milligram. So the first dose is 1 milligram. Next, you add another 1 milligram. Next, you add another 1 milligram up to 3 milligram. If this fail, you choose other, you want to use IVI dopamine or IVI adrenaline. And consider if your intravenous medications fail, uh, you might need to do transcutaneous pacing. Tachycardia is when the heart rate is more than 90. However, if the heart rate reach more than 150, always think about tachyarrhythmia. And common types of tachyarrhythmia commonly seen in emergency department is the narrow, complex and regular, which is SVT, or narrow complex irregular, which is AF, and not to forget the wide complex regular, which is VT. There's also a condition called polymorphic VT and torsade de poids in a wide complex irregular rhythm. Same with the bradycardia, we need to assess the stability of the tachyarrhythmia. Again, the 5 things start from the head, whether there is altered mental status, goes down to the chest, whether any evidence of chest pain, then the lungs, when any acute shortness of breath, then whether go to the arm for hypotension, and the peripheries, whether any evidence of cool and clammy due to shock. If all the questions were negative, means it is stable, we treat with drugs. If there any evidence such as hypotension, we are going to cardiovert the patient. In order to manage tachyarrhythmia, it goes with the similar algorithm, the basic life support. They initiate that. Then if there any evidence of instability, we immediately synchronize cardioversion, and if stable, we're going to manage with pharmacological treatment. Okay, this picture just show you the difference between the shock and synchronized cardioversion. In synchronized cardioversion, there will be the word sync, and there will be markers on top of your QRS complexes. This is absent when you shock the patient in cardiac arrest algorithm. And so this is the marked difference between synchronous cardioversion and defibrillation. Different waveform need different biphasic energy when you synchronize cardioversion. Uh, Basically, the lowest is 70 joules in SVT, and others need between 120 to 150 joules for synchronous cardioversion. In summary, effective ALS begin with high quality CPR. Always check the high quality CPR. You need to recognize and treat the arrhythmia early, and during this course when you stuck doing resuscitation, always ask yourself, for the reversible causes. Post-resuscitation period is important and know the algorithm well. With that, thank you. I hope to see you in the skill station. Have a nice day.